So can you see my screen? Hello.
We can see your screen.
Okay, so good morning again. My name is Dr. Boru Okotu, as I've been introduced, working at the National TB Program, coordinating TB, HIV, and lung health. So today we are going to go through introduction to TB, and we will also look at the epidemiology of TB. So by the end of the session, these are the expected learning outcome. Define TB, state the cause of tuberculosis, list the risk factors for TB. It should also be, you're also expected to know signs and symptoms, the cardinal symptoms of TB. You're also expected to describe global burden of TB as well as the national TB burden in Kenya. Then we'll also briefly look at the Ntp strategy and the global targets. So we'll start with basics of tuberculosis. Tuberculosis is an infectious disease that is caused by a bacteria called Mycobacterium tuberculosis, which it is estimated that 1.7 billion people, that's about more than 20% of the global population, living with latent TB infection, and out of which about 15% will develop TB disease during their lifetime. TB spreads from infected person to uninfected person through the air, and this bacteria gets into the air when that person coughs, sneezes, laughs, talks, or sings, or any other action that releases these aerosols into the air. The bacteria is transmitted through, yes.
I interrupt you for a bit. Could you kindly put your slides on slideshow? Yes.
Sorry. Yes. So MTB is transmitted through the air and not by surface contact or shaking hands, as opposed to, as we all know, the pandemic, the coronavirus that is transmitted through surface contact or shaking of hands. So TB is purely through the air. Transmission is through the air. I know there are some myths that when you share utensils with someone with TB, you will get TB. But the fact is that TB is transmitted through the air and not through contacts, physical contacts. So the basic of TB disease, TB usually affects the lungs, but okay, in majority of the cases, TB affects the lungs, but it can also affect all other parts of the body, except the ear, the nails, and the teeth. So every other part of the body can be affected by TB. Diagnosis of TB of the lung, called the pulmonary TB, is through the examination of the sputum, either using microscopy or gene expert. But the investigation of choice now is in Kenya is gene expert, where it is available. Only when it is not available that we can do microscopy, but still we send samples for gene expert where through sample networking where it is available. TB treatment takes at least 6 months, and the adherence to TB treatment is paramount, because if you don't complete TB treatment, then you will be a potential candidate for development of drug-resistant TB. So adherence is very key in TB treatment. So a little bit history of TB globally. TB mortality has fallen by about 70% since 1990, with nearly all of that improvement taking place since 2000, when the MDG, the Millennium Development Goals, were set. About 49 million lives have been saved between 2020 and 2015. The Millennium Development Goal targeted to halt and reverse TB incidence has been achieved on a worldwide basis in each of the 6 WHO regions, including the Afro region, and in 16 of the 22 high-burden countries that collectively account for 80% of TB cases. Globally, TB incidence has fallen by an average of 1.5% per year now since 2000, and is now at 18% lower than in 2000. Generally, there is a 4 to 5% annual decline needed to reach the 2020 milestone of the Ntp strategy. So TB, generally, we divide TB into 2: TB within the lung, that is pulmonary TB, and extrapulmonary TB, which is TB outside the lung cavity. Pulmonary TB, which is also, put into initials as PTB, can be diagnosed in 2 ways. One is by bacteriologically confirming using GeneXpert, that is using the sputum as the sample, and investigated using GeneXpert or smear microscopy. Those that are not able to be diagnosed through laboratory diagnosis are diagnosed using, we call them clinically diagnosed PTB, and this includes X-ray or just using clinical criteria based on the signs and symptoms of TB. So for extrapulmonary TB, we've said that all the organs except nails, hair, and teeth are affected. So other organs such as lymph nodes, pleura, pericardium, meninges, bone, spine, what have you, can all be affected by TB. So we briefly look at TB transmission from exposure until the person falls sick or develop active TB disease. Is that we have said that TB is transmitted through the air and not through the surface, contact with the surface or handshake, as we've already alluded to. So exposure happens when a source case with an active TB disease exposes a healthy individual through the actions that we've already mentioned, such as cough, sneezing, singing, and any other cause that brings out those aerosols into the air. Release of those aerosols into the air. Then this bacilli can survive in the air depending on the factors that support their survival, such as maybe unventilated rooms, the flow of the air, and so on, direction of flow of the air. So based on these factors, the bacilli can remain in an enclosed place up to like 72 hours. And so the person's who will be within that space, within the given period, will be exposed and will inhale these bacilli, where they'll get infected with these bacilli. However, we said that about 90%, 70 to 90% of the people who are exposed to TB bacilli might not develop TB at all, might not develop infection, at all, while about 10 to 30% will develop infection, will have the infection latently. They will not show any signs and symptoms, and they can live with that infection all their life, unless other factors that will help progress the latent infection on active TB. So the natural history of TB infection is that once infected, the bacilli passes through the respiratory tract to the alveoli, where some of the bacilli are killed using the body immune system. A few might multiply in the alveoli, while others may enter the bloodstream and spread throughout the body. Within 2 to 8 weeks, special immune cells called macrophages ingest and surround the tubercle bacilli, and here we will consolidate them into a foci called Ghon's foci, and they will be destroyed mostly as long as the immune system is strong enough. Much of the bacilli will be contained through formation of barrier called a granuloma that keeps the bacilli contained and under control. So that is what we call now the latent TB infection. If the immune system cannot keep the bacilli under control, then it will begin to multiply and rapidly spread across the body. This can occur in different areas of the body, as we've already seen, except those 3 parts of the body that TB does not affect. So we say if the immune system of that individual is not strong enough, the bacilli can overcome the defense of the immune system and begin to multiply, which then results into development of signs and symptoms and cause what we call active TB disease. 5% of those 10% that we mentioned that have a chance of developing lifetime TB during their lifetime will develop within the first 2 years of infection. This we call primary TB disease, and that's just 30% of the population that got infected, 5% of those that have got infected with TB. And this usually occurs in young children or in severely immunosuppressed population, maybe those who are elderly, very young children, those with other comorbidities. 5% of this developed of the people who have who develop TB will develop this once the immune system will go down. So, and this is any TB infection that progresses into active TB disease after the 2 years of exposure is called secondary TB. And this can be as a result of reactivation of latent TB, or can be as a result of reinfection by new bacilli that were not which were not the ones that cause there will be, it will not progress to latent TB at all. So, either this latent TB will, well, the 10 to 30% will have the infection in their body, and they'll be having the what we call the latent TB, which do not develop into TB, active TB disease, and therefore they are not infectious, since there are no signs and symptoms. There's no coughing. There's no release of aerosolized bacilli to expose the healthy population to infection. About 10% will develop TB, we said, in their lifetime, and out of these 5% will develop that TB, will develop primary TB within the first 2 years, and 5% will develop TB many years later. They might not even develop at all, or they develop once the immune system is compromised. So that's about another 5%, and this is called secondary TB. So this population, if treated, they get cured. Majority will get cured as long as they adhere to treatment, and they don't have resistance to the drugs. So if this population is not treated, then 50% will die within the first 5 years, and this is what happens usually, very early in the years before the World War II, Second World War, that is, when there was no drugs. People diagnosed with TB were just taken to sanatorium, especially there in Europe, where the health system was already developed before African countries or continent. So they are left to die peacefully because there was no treatment. So 50% of these TB patients die within 5 years from diagnosis. 25% of this population with active TB will recover owing to their strong immunity, but 25% of them remain sick, and therefore they continue transmitting TB. And this is the population that we need to actually find in the community. These 25% that do not either die or do not recover are the ones that pose all the risk of exposure to TB in the population. So signs and symptoms of TB. For adults, patients might present with cough of any duration. Previously, we said that the cough of more than 2 weeks, but that has changed since. Cough of any duration should raise your suspicion for TB, and such patients be investigated along that line. Drenching night sweats, unexplained weight loss. I know this is not the weight loss, the intended weight loss for people who might think that their BMI is high and so they want to intentionally lose weight. That can be explained, but unexplained weight loss, patients come with weight loss maybe over a period of time. Will give you heads up on, suspecting TB in such patients. Blood-stained sputum also remains a differential, as much as probably these patients you need to also suspect other conditions, lung conditions. TB is also one of the differentials. Fever as a general symptom is also a very common symptom in TB. Chest pain, shortness of breath. Those are things that once you suspect, once a patient presents with these symptoms, you need to suspect TB. In addition, for children who probably could not explain themselves in terms of how they feel and what is going on in their body, we can estimate, or we can find or suspect TB among those young children who have failure to drive, or they do not gain weight, or poorly gain weight. Then another one, very young children who do not play actively, who are lethargic and irritable, will all point towards suspecting TB among them. So any of these symptoms, we are not saying that all the symptoms should be present for you to suspect TB. If any of the sign and symptom is present, you need to rule out TB before you discharge the patient on other medications. People at risk of TB. So, so who are these people that are at risk of getting infected with TB? We've already said that people, the extremes of ages, very young children, the elderly people, those with comorbidities such as diabetics, people on immune compromising treatment or therapy, such as, those people on steroids, or people on other drugs affecting the body's defense system. People who live in overcrowded or poorly ventilated houses or vehicles, those people in informal settlements, and living in in overcrowded small houses are at increased risk than the general population, because we've said that TB is transmitted through the air, through aerolization of those actions that we've already seen. And so if there's a small room or a house with one room where 10 people live, so obviously these people will be exposed to TB. Not only the houses, even the vehicles. Sometimes people might travel in a vehicle which is crowded. For example, our public service vehicles, the matatus, where instead of 10 people, maybe 18, 20 people will be traveling in. Those people, or if there is anyone who has active TB, then they are exposed to TB infection. Also, people who are dependent on drug or alcohol, especially those who share those who share the needles, those who are active abusive drug users who are injecting themselves with drugs, could very easily expose each other. So in summary, we've seen that TB is an infectious disease that is caused by a bacteria called Mycobacterium tuberculosis, which is transmitted through the air. TB mostly affects the lungs, but can also affect other parts of the body, except those three parts of the body that we said are not affected. There are two types of TB, pulmonary and extrapulmonary. We've also seen 90% of latent TB never develop into active TB and is non-infectious. GeneXpert and AFB microscopy are mandatory tests for all presumptive TB cases. Presumptive TB cases are those that we previously called suspected TB. These days, the term suspected has been changed to presumptive because of the fact that suspect could be something that the person is liable to, somebody is guilty of something. So WHO has recommended the word presumptive to replace suspected TB. TB is treatable using fixed dose combination. Okay, so that is the basic fact about TB. And finally we go to introduction to epidemiology. Here we will look at the global statistics about TB and the targets. We look briefly at NTP strategy of 2018-2020. We look at the Kenya TB epidemiology. We look at the case finding and among the different population levels or strata. Then we'll look at the prevalence and the incidence and mortality rates in Kenya. So this slide shows global TB statistics. This is data from 2018, published in 2018, that about 10 million people fell ill with TB that year. So as opposed to in 2017, about 7 million people reported to have access to TB care, while in 2017 there were 6.4, so about 600,000 increase in access to TB care. However, 3 million were undiagnosed or not reported. As we will see in the next few slides, we are going to see that in Kenya, the picture remained the same. We are not able to get and diagnose TB cases, all the TB cases in the community. So quite a big chunk of TB cases, the 25% we have just we've looked at in the previous slides, are in the community transmitting TB disease or TB infection. So out of this 10 million, you can see 1.5 million people died from TB, including 251,000 people with HIV. As opposed to, the perception that TB, if you have TB, you will have, or the most cause of death, the most common cause of death among TB patients is HIV. As you can see, out of 1.5, only 250,000 were people with HIV. So as long as TB patients have access to HIV treatment, the ART, then their survival potential is as good as those populations with TB but without HIV, as can be indicated by this report. So in the same year, about 500,000 people fell ill with drug-resistant TB. But as of that year, only a third of the population with DRTB or drug-resistant TB access treatment. So global targets is that the NTP strategy and the Sustainable Development Goals have set targets to be achieved by the year 2035 for NTP strategy and 2030 by Sustainable Development Goals. These are the goals that were set after the end of Millennium Development Goals that came to an end in 2015. So here we are looking at about 3 indicators. One is reduction in number of TB deaths compared with the 2015 proportions. And by 2020, we are supposed to have reduced TB deaths by 35%. In 2025, we are supposed to have reduced it by 75%. And by the end of SDG 2030, we're supposed to reduce mortality due to TB by 90%. And by the end of NTB strategy in 2025, we are supposed to reduce it by 95%. So by the end of NTB strategy, of in 2035, we'll have only 5% of TB patients dying. Probably this is because, you know, death is inevitable. There could be other related causes, but there are those causes of death that can be avoided. And so that's the one that is targeted by the SDG and the NTP strategy. So only 5% will be expected to die of TB by 2035 globally. The other factor, the other indicator that we are looking at is reduction in TB incidence rate to about 90%, by about 90%. So by end of TB strategy, we'll have only 10% of incidence TB as compared to what we had in 2015. The third indicator is TB affected families facing catastrophic cost due to TB. This needs to be reduced to zero. They are not supposed to face any catastrophic cost, any cost in accessing TB. So cost should not be a barrier to access to TB care. Because in Kenya currently, TB treatment is free in all the public health facilities, but there are other indirect costs that probably hinder the patients from accessing these services, such as transport costs. So depending on the facility, location of the facility where the patients are accessing their treatment, transport costs can be a huge barrier to access to TB care. So the NTP strategy to achieve global targets focuses on these three pillars. One is integrated patient-centered TB care and prevention. I hope we are together. Am I audible enough? Hello.
Yes, you are, Doctor. I can hear you.
Okay, thank you. I thought I was talking to myself. Okay, thank you. So integrated patient-centered TB care and prevention is pillar one in terms of the NTB strategy targets. Then pillar two is bold policies and supportive systems. In the integrated patient-centered TB care and prevention, we are looking at with the previous slide, we have looked at the catastrophic cost in terms of indirect cost that prevents the patients from accessing quality TB care. And if this is taken care of, then this is a patient-centered kind of care. And number two is when, for example, patients, TB patients come to the health facilities to collect their medication maybe based on the clinics as they are booked or appointment given on a specific clinic day. This sometimes inconveniences patients because, you know, the different populations have different needs, different, time for what they want to do. For example, there are people who are who go to very busy offices, and so they cannot be at the facility maybe at 8 a.m. or even 10 or 11 because they're in very busy offices. So they want to probably, you know, have the clinics booked according to their convenience. There are others who probably are available from 8 to 5 and they can come in anytime they want. There are others who want to come maybe early before 8 or later in the evening after 8, after 5. So patient-centered care means now is that you need to consider the patient needs and give them appointment based on their need and not based on what the facility set for them. This is all to prevent, you know, dropout of treatment because of those inconveniences. We have in the guideline what we call differentiated service delivery, where now patients are given appointment based on their need. If they want to come very early in the morning, if they want to come after 5, they have to be, that need have to be considered. Number 2 is also there is community-based drug delivery by community health volunteers who are sensitized on TB treatment. So these patients who are busy probably on their duties can be, or who are not able to actually come because of different various circumstances, can be delivered their medicine at home, but come once in a while for review. So that's in terms of differentiated service delivery, in terms of care, or in terms of treatment. Same applies also to diagnosis of TB patient, TB in a client who is presumptive TB. Integrated care means that maybe this patient is on multiple drugs. Maybe it's an TB HIV co-infected patient, and this patient need to access this service promptly and go on with their daily activities. So integrated means that if the patient comes to collect TB drugs, it should be able to collect other drugs. For example, the HIV treatment or the ART should also be collected under the same during the same visit. So here we have different levels of integration. We have the integration in terms of under one building, under one roof, and the same room where the same clinician offers the services, for example, TB services and HIV services. And once the patient is done with this room or with this clinician, is done with collecting all the drugs and they go home. The other one is probably under one roof, but different rooms where there are different clinicians offering the services for TB, another one for HIV. So a talkative from this room goes to the other room without going, far distance, and they get served promptly and they go. Another one, which is also a model of integration, is in different buildings, but within the same facility. And here patients are linked through probably a linkage assistant in form of probably a CHV or even a healthcare worker who will accompany this patient to the next clinic if it is not under the same roof. So the second pillar is on bold policies and supportive systems, that we need to have policies that are centered around the patients rather than policies that favors the health system or something like that, so that these policies will support adherence to TB care, improved access to services and so on. So pillar 3 is intensify research and innovation, where now the research is based on the challenges, the areas that need to be improved in terms of even, for example, treatment of TB. We are currently doing about 6 months therapy, down from I think 12 months some years ago, and there is still hope. 6 months is quite a long time, and usually the patient might end up defaulting or going out of control, lost to follow-up because of that long period of treatment. There are studies going on to research into possibility of having shorter drug regimen. For example, 4 months is already, I think, in study, and hopefully we'll go to that 4 months very soon, and maybe going further, we'll get effective drugs that can cure TB within a very short period. So this, in terms of these pillars and their components, the pillar 1 is about early diagnosis of TB, including universal drug susceptible testing. I've already gone through this. Treatment of all people with TB, including drug-resistant TB and patient support. Collaborative TB HIV activities, for example, integration of services. Preventive therapy. Ball policies and supportive systems. That in terms of that pillar 2, we have political commitment with adequate resources for TB care and prevention. Engagement of communities, civil society organizations, and public and private care providers. And universal health coverage policy and regulatory framework for case notification, viral registration, quality and rational use of medicines and infection control, as well as social protection, poverty alleviation, and actions on other determinants of TB. So in terms of the third pillar, intensify research and innovation, discovery, development, and rapid uptake of new tools, interventions, and strategies. Research to optimize implementation and impact and promote innovations. So what are the indicators and the milestones and targets of the strategy for NTP strategy? So the vision of NTP strategy is a world free of TB. There should be no deaths. There should be 0 deaths due to disease, due to TB. There should be no suffering due to TB. So in terms of reducing even morbidity, not just the mortality. So the goal is end the goal TB epidemic and end the global TB epidemic. In terms of the indicators, we've already seen reduction in number of TB deaths compared with 2015, reduction in TB incidence, and TB affected families facing catastrophic costs. And the milestone so far is that, the expected milestone is as indicated on the screen. So there should be no cost relating, whether direct or indirect, relating to TB care. All the costs should be taken up by maybe the government or the partners, mostly. So reduction in incidence rate compared with 2015 is as indicated also. So what are the principles of NTP strategy? 1 is government stewardship and accountability with monitoring and evaluation. Strong coalition with civil society organizations and communities. Protection and promotion of human rights, ethics, and equity. Adaptation of the strategy and targets at county level with global collaboration. So this indicates the estimated TB incidence rates 2019 globally. As you can see, Kenya, we are notifying about 200 to 299 per 100,000 population in terms of estimates of TB. So we are in high burden countries. So HIV prevalence in new and relapsed TB cases. So this indicates distribution of TB HIV confection across the globe. And again, Kenya, about 20 to 49%. We are at about 24%, as we are going to see in the next slide. TB mortality rates in HIV negative people. So we've seen that the mortality of TB globally is not contributed by HIV in this era where patients are immediately initiated on ART. So that ART has reduced TB mortality, TB related mortality among HIV patients to the level of TB only mortalities. So finally, let's look at the statistics of TB in Kenya. In 2020, we notified about 77,000 TB cases, and our estimate for TB case finding is about 140. This is based on the previously done prevalence survey in 2016 that showed that the estimated incidence for TB is about 140 with a prevalence of about 426 per 100,000 population. So we are able to get just about 60% of the cases annually. And so we are missing about 40% of cases every year. And this 77,000 is actually an increase from the 2020 case finding, where we got about 72,000, close to 73,000. So we have increased in 2020 by about 7%. So in drug-resistant TB case finding, we had about 804 cases notified, and this was a drop from 2019, where we got about 900 cases. Pediatric TB case finding is estimated to be about 10 to 15% of the cases notified. And in 2020, we notified about close to 10% pediatric TB cases. And this was actually an increase from 2020 by about 20, from 2019 by about 32%. This slide shows a snapshot on case finding and treatment outcomes for TB in Kenya. We've already looked at DSTB. DSTB is drug susceptible TB, and DRTB. DRTB includes both multi-drug resistant TB and monoresistant TB, including rifampicin resistant. It also includes the XDR-TB. So that in general we call drug resistant TB. So in terms of public and private sector contribution, 80% of our cases come from public sector and about 20% from private sector. In terms of surveillance, surveillance now in this case means using GeneXpert to diagnose TB and also determine rifampicin resistance, as well as taking sample for culture and drug susceptibility testing for other molecules in the TB drugs. So we were able to do about 76%. Ideally, especially for previously treated TB, we are expected to do surveillance for all the patients who are suspected to be DRTB, who are potential DRTB. HIV testing in the year 2020 was about 97%. And in terms of treatment outcomes, 71% was the cure, and the treatment success rate of about 84%. Then we also look at the TB preventive therapy. TB preventive therapy is currently happening in Kenya, and there are categories of people or clients that are expected to be initiated on TB preventive therapy, and that the detail will come in the next presentation. But in terms of contacts, which is one of the categories that need to be initiated on TB preventive therapy, the household contacts, about 9,000 people were contact listed. Those are contacts of bacteriologically confirmed cases. Once we rule out active TB through symptomatic screening, including even X-ray, we initiate them on TPT. Previously, we had isoniazid preventive therapy. Now it has been expanded to include other medicine, as will be shown in the next presentation. So this is trend of TB case finding from 2011 to 2021. Before the prevalence survey was done, we thought that we are actually achieving the target of eliminating TB, because we were seeing reducing trend of TB case finding. As you can see, from 99 to 99 in 2011, 99,000 in 2011 to 75,000 in 2016 when the prevalence survey was conducted. And based on the results, we realized that actually we were missing a lot of cases. And from 2016, there was a sharp rise until 2018 of TB cases to almost 100,000 before we started again going down. But I think the COVID-19 outbreak played some role in the reduction in the case finding of TB. But in 2021, we have started seeing rise in case finding. So that is case notification rate in Kenya in 2020. That shows the case notification, TB case notification change in 2020, 2021, in the era of COVID-19. This shows that the most increase, some of the counties had shown increase in TB case finding despite the outbreak and the effects that has brought to TB case finding. For example, Siaya was able to notify almost 35% more cases than the previous year, while Kericho was able to notify about 8% increase in TB case notification. So this slide just shows the number of, the counties that have posted increase of more than 7% in the year 2020 of TB cases. While this one shows those counties that had posted increase of up to 7, or others that actually reduced. As you can see from the slide, Garissa posted reduction in TB cases by about 9%, and Migori about 7% increase. There are other counties that were not affected. For example, Nyeri and Isiolo did not change in terms of TB case notification. So they either showed similar, or they posted similar number of patients as the previous year. So this is trends of bacteriologically confirmed patients in Kenya, TB patients in Kenya between 2012 and 2020. Ideally, all TB patients need to be confirmed using AFP microscopy or GeneXpert. But the investigation of choice for the program now for Kenya is GeneXpert first, and if it's available, if it's not available, maybe you collect sample, send for GeneXpert, but you can do a microscopy if it is available within the same facility. Because some patients, you'll find some patients are very, are obvious TB cases. You just need to confirm. So such cases, you will just do the microscopy, but you need to also confirm, even if you have confirmed TB with FP microscopy, it's only diagnosis. GeneXpert will give you a resistant pattern for GeneXpert. I mean for rifampicin. Yeah, so this indicates the trend of bacteriologically confirmed cases. Initially, we were low, and as we have more sensitive tools to investigate and diagnose TB, that is in form of GeneXpert, we are now having higher proportion of TB cases confirmed bacteriologically, as opposed to initially when we used to have clinical diagnosis more than the bacteriologically confirmed TB cases. So this slide showing the HIV testing, and overall, the country is testing about 97% of TB patients for HIV. And you can see some of the target is 100%, and you can see some of the counties posting close to 100%. For example, Homa Bay is posting about 97-something%, more than 97%, while the list, Nairobi, is posting about 96%. So the country is testing about 97%. We are almost at the target, testing almost everybody. So co-infection rate is at 24% as of 2021. So once a TB patient has been diagnosed with HIV, we encourage immediate initiation on ART based on tolerance of TB treatment. So our patients, most of them are on treatment. ART uptake is about 96% across the country, and many of them are above 90%. So contribution by private sector over time, from 2015 to date, has been oscillating between 18 and 21. And in 2021, we posted about 20%, and actually the target is a changing target. So currently we are 20%, and once we meet that, we'll keep on working on the target and keep on engaging private sector to take up more TB care, more in TB care, because about 48% of healthcare in Kenya is offered by private sector, and so there's no reason why we cannot have 40, 50%, 60% of TB care offered by private sector. So finally, in summary, we have looked at the global statistics that about 10 million people fall ill due to TB annually, globally. Ntp strategy aims to reduce TB incidence and mortality by 90% and for 95% respectively by 2035. It has 3 pillars, as we had seen. Kenya is in the high burden for TB, triple burden of TB, HIV, and DRTB. Thank you. Back to you, Chair.
Much, Dr. Guru, for your presentation. Rhoda, are you still with us? So as we wait for Rhoda to come back online, Daktari, while you're having your presentations, we got a few questions that you can, on our Q&A section. Well, Mr. Collins Oliech is asking, is it possible to get TB if you are once contracted?
Yeah, so I can see the questions on the chat. Maybe I can answer them.
Okay.
Yeah, so is it possible to get TB if you were once contracted? Well, yes. You know, TB does not infer a lifetime immunity. So once you get TB, you can be treated, you get cured, but you can still be infected with TB. Yeah, so it is possible you can be infected or you can contract TB again. The second question by William Kigo is, if one has started medication, is he or she able to transmit the bacteria? Yeah, once TB treatment has been initiated and it's an effective treatment and the patient is adhering to TB treatment, the TB drugs are very, very effective drugs. So within the first 2 weeks, the person becomes uninfectious. So they will not be transmitting. Okay, let me not say they are not transmitting, but the infectiousness reduces with this initiation of TB treatment. So probably within the first 14 days up to 1 month, they become less infectious until maybe by the time they're in continuation phase, they do not transmit at all. And you know, as we have seen, TB is transmitted through the air, through aerolization, when a patient coughs or produces the aerosols into the air. And so once they are started on treatment, these symptoms will disappear. And so if they have no symptoms, if they don't cough, then they will not produce the bacilli. So in that way, they become less infectious. Crispin Onyangigo says, if TB is such a global challenge, then why immunize? Does immunization really work? What is the correlation between non-immunized and exposure? Fatality rate.
Hi, Dr. Ari, how are you?
Yes.
Sorry, I'm sorry I had some technical challenges. That's why I joined in late. Let me assist you with at least the question so that it's not as monotonous. Something you had mentioned before you answered Christine's question about COVID-19, the TB rates going down from 2018, especially when COVID came. From your observation, was it because the clinic visits were less, or was it because COVID, the face masking actually reduced transmission rate? Over to you.
Well, it's possible that the use of mask, those preventive measures against COVID, might have helped. But I am hesitant to attribute the whole reduction in TB cases to that, because it's
and I can fairly agree, because most of the times people are not coming to hospitals or clinics because of fear of contracting COVID. I'm not sure what was happening in the clinics in TB. Did they have a reduction even in known cases of TB? What was the strategy you had applied? Were you giving them drugs for a longer period?
Yeah, what happened is that actually the cases reduced in 2020, but in 2021 it started rising. And in 2021, until recently, we were still using the mask. So that means that there's that period when the government had put restriction measures in place, that patients, once you start showing symptoms such as cough, you don't visit the facility, you call, having in mind that this probably is a COVID. So some of those cases were TB. And so if they did not call and they were told not to visit the facility, they will continue, or before they visit the facility, they will continue transmitting TB. Even if they call and the response team, the COVID-19 rapid response team visit the facilities, they collect the sample and they leave them. And if it's not a very severe thing, they just cough and they move on with their life. And if the result is negative, they are communicated back to them, and they continue living. And you see, some of them might be TB, and they continue transmitting. And number two, in terms of the mask and all that, I participated in a rapid response for COVID-19, and we've gone to several informal settlements where wearing mask rarely happens. So that issue of because of those preventive measures such as wearing mask has reduced, maybe in a certain strata of the population of the society, it might have worked. But in generally where TB is very common, mask utilization was not as high. Yeah.
And I totally agree. I can see Rhoda has joined in. Her presentation is ready. But I remember the first case of TB that I came across in Kenyatta, who had TB. Unfortunately, they also had MDR. It was such a challenge knowing where to put them in isolation. But let me leave you at that. So Rhoda, thank you for joining us. I can see your presentation is online. We can continue with the question and answer after your presentation.
Okay, thank you everyone. Kindly confirm you can hear me. I am on the road, but I've parked somewhere. I hope we'll be able to, my network will not fail me. So somebody confirm you can hear me and also see the presentation. Awesome.
Yeah, thank you.
Okay, this is usually a module to be done in 2 days, but I'll only pick the slides that are relevant for this particular meeting, hoping to do this in the next 30 minutes. Okay, so we're going to discuss about latent TB infection, and this is the reason as to why we are offering TB preventive therapy. Okay, this background has been explained much by Dr. Boru. The epidemiology bit I will skip because Boru has elaborated on this, the burden, but I will start from here. So what you see here, this is we have what we call the National Strategic Plan for the program, which runs from 2019 to 2023. And we have a number of priority outcome targets by 2023. So the first target is to diagnose and treat at least this number of people for TB. But now they've been categorized into children, adults, and also DRTB. But why we're doing this is because of the second group. We also have a target of offering TB preventive therapy to about 900,000 people who are at risk for TPT. Okay, we'll skip these trends because Boru has elaborated much of that on them. These are just milestones of some of the things that we have done at the program. Maybe just to mention that in 2018, WHO gave some new recommendations on management of latent TB infection, and then recommendations included offering TPT to an expanded population. Earlier on, before this, we used to offer TPT to people living with HIV and also household contacts who are below 5. But now it was shown that the risk is even beyond these two populations, and all of them need to benefit from TPT. The other recommendation was the use of shorter regimens. We all know of 6 months of isoniazid, what we used to call IPT. But now in 2018, there are shorter regimens that were also included in the list. We will learn about them in the course of this particular session. So now, as a country, we did not have any document. We did not have a policy document on the same. So we had to work on a process. So we developed a policy, or we reviewed the WHO policy and picked a few things that we adopted as a country, and also putting in mind our status. We are not a very resource-rich country. So we had to develop our policy, and our policy was launched in 2020. Our policy is also available in our website. Those of us that can access the TB website, just search for LTBI policy. After that, we went ahead now to develop guidelines, healthcare workers guidelines. That's very soon you'll start receiving them. I don't know which counties you work in, but we are in the process of printing, and very soon they'll be distributed. We also have SOPs. We also reviewed our data collection tools. So the data collection tools here, we have a TPT register, we have record cards and the likes. And then finally, we went to the rollout. So the rollout started with the sensitization of the national teams. Here we sensitize the partners that support TB and HIV programs. We also train the program officers from the National TB Program and also from our sister program, the HIV program, NASCOP. And now we went ahead now to provide commodities and also support. So these are some of the things that we had planned to do. And I think for this particular sensitization, we'll be covering this particular part here. Is it this one? Or yeah, I think these two. So after the national team was sensitized, we went ahead to sensitize the county and the sub-county TOTs, who majority will be interacting with you at facility level to also capacity build the healthcare workers in our different facilities. So these TOTs will do on-job training and also capacity building at facility level. So what we're doing today is part of this. The sensitization learning is a continuous process, and we do it in various ways. Right now we have the e-learning models that can also help us to reach to a number of healthcare workers. I am glad that this webinar today has enabled me to reach to 423 healthcare workers, which is a good step in terms of cascading the knowledge. The rest here is about procuring the commodities, printing of the guidelines and distributing, offering continuous technical assistance visit like what we are doing right now. We are doing a TA in Nairobi to assess the uptake of TPT post the healthcare workers initiation. Okay, now we go to the content. We will define a few terms so that now going forward, it is easy for us to understand what you're talking about. The first thing that we need to define is what latent TB infection is. So by WHO definition, this is a state of persistent immune response to stimulation by MTB antigen with no evidence of clinically manifest active TB. So it's a situation where you have been exposed to the TB bacilli. Maybe you have lived with a person that has tuberculosis, or maybe you're a healthcare worker that you have sub-patients that could were coughing in the outpatient or even in the wards that were coughing. So it includes the undiagnosed and the diagnosed. So as long as you've been exposed to the TB bacilli, but you're not showing the signs and symptoms. So your body or your immunity is able to contain the disease, and then you're not showing signs and symptoms of TB, so the bacilli is in a dormant state. But now when your infection, your immunity goes down, then you're likely to start manifesting the signs and symptoms. The bacteria will be replicating, to be live in your body, to be replicating, and now you move to a stage that is called TB disease. So TB disease occurs now when the exposed person to TB bacteria develops the signs and symptoms of tuberculosis. But we also need to define what TPT is, because some of us continue calling it IPT, IIT, some very funny abbreviation. But TPT is now the treatment offered to these individuals, the ones that are considered to be at risk of TB, in order to reduce that risk. So why we changed from IPT is because initially we just were using one drug, the isoniazid preventive, so we used to call it isoniazid preventive therapy. But now we have other drugs beyond isoniazid, so now we call it TB preventive therapy. The other thing that we need to understand is who our household contacts is, because we realize in our presentation that one of the population that needs to benefit from TB preventive therapy is the household. So who is the household? So by WHO gave a very broad definition that includes a person that you have shared daytime periods and also nighttime periods and also extended daytime periods with a person that has tuberculosis. And this should be like 3 months before that the sick patient was was diagnosed and put on treatment. So by this definition, then it means if you have a workmate, a classmate who has tuberculosis, you were in the same class maybe for that period, 3 months before the case was diagnosed, you are sharing extended daytime periods. If it's our workmates, you're sharing the most of your daytime periods with them, then you qualify to be a household contact. But just to mention, if when it comes to offering now TB preventive therapy, we will not be able to reach to that, because now you realize that will be a very big population. One TB patient will have the household contacts, and beyond that, the workmates or the social contacts to be included. So the resources required for that might be too much, which for us as a country, Kenya, a resource-limited country, we may not be able to reach to all contacts by that definition. So in terms of offering TPT, we will narrow down our TPT to just the household contacts. So you get backed confirmed TB patients, you ask them, whom are you living with? And these are the ones that will benefit from TPT. And also just to mention, we have schools, maybe some of us will be managing schools. In schools, the scenario will be different, because boarding schools specifically, we will treat the dormitory members or the cube members as household contacts. because now those ones will be sharing the same nighttime period. So the assumption here, all of them are at risk. The people that you spend time with in the day, and also the people that you spend time at night, they're all at risk. But the risk is higher among the people that you spend nighttime period with, because at night we're in an enclosed room. We have closed the windows because it is cold, and also for security purposes. But the risk of the people that we spend daytime periods is lesser, because most of the time we've been outdoors. We'll be in maybe a larger halls for the students, maybe for the workmates. Most of the time, maybe you'll be doing a ward in a bigger ward, so the risk is lesser. But if you had adequate resources, then we would put all these people at on TPT. And just to mention that, much as we're not going to offer TPT to the social contacts, efforts to do contact screening should be done to all. So you have TB in school, a TB patient in schools, just screen the entire school or the entire class. But now when it comes to TPT, that's when now you narrow down to the household members. So the burden for latent TB, it's estimated globally that 1/4 of the world population have latent TB. However, not all of them will progress from latent to active. So the risk of progression varies. It's estimated that 5 to 15 of those who are infected will progress to TB disease, usually within the first 5 years after initial infection or after initial exposure to the TB patient. So these people that are latently infected form as a reservoir for a significant proportion of the emerging cases of TB. So a number of the patients that we are managing today for TB were once latently infected, but maybe because of the immune status, immunity went down, and now they came down with tuberculosis. So that is to say, then if you manage the people that are latently infected in future, then you're likely to reduce the burden of tuberculosis in the country. We did a small survey in Kiambu, where we tested a number of healthcare workers with IGRA. IGRA is one of the new diagnostic option or test option to pick exposure to TB. So in Kiambu, we sampled a few facilities and a few healthcare workers from different departments, from the wards, from the outpatient, from the lab also. And what we did, the first thing we did for these healthcare workers, we screened them for TB to ensure that you do not have signs and symptoms. Remember, we said people that are latently infected, the bacilli in them is dormant. So definitely they will not show any signs and symptoms of TB. So we ruled out the signs and symptoms of TB, and we made sure that the population that we're dealing with do not have signs and symptoms of tuberculosis. So when we did that, now we subjected them to the IGRA tests to see if they will test positive. An IGRA test is more of an antigen antibody test, and it's able to detect a reaction, to pick a reaction if somebody has had the exposure to the TB bacilli. So we were surprised, much as in the first bullet we're talking about 1/4 of us I estimated to be latently infected in Kiambu, and maybe most of us as healthcare workers, the story was different. So about 80% of the healthcare workers turned positive. So this shocked us, and we decided, much as the way we have been handling PLHIVs and contacts, then we need to also include healthcare workers as a risk population to benefit also from TPT, bearing in mind our work environment and the likes. We have been exposed left, right, and center to this bacilli. Okay, but no, we've not been able to do any study to the general population to ascertain the burden of tuberculosis. But what we are thinking is it could be something closer to what we saw in Kiambu. Natural history of progression, I think this is maybe common knowledge to all of us, but what happens when you are exposed? A big proportion will not develop any infection, will not get any infection, but about 10 to 30% will get the infection. That's why we're saying 1/3 of the world is likely to have a latent TB infection. But now from this, there are those that will straight away go ahead and develop active TB, 10%. But a majority will stay in latent period for some time, and 10 to 15% are likely to now progress to TB within 5 years after exposure. And this is the group that will have benefited from TPT, and that's why we are doing this. So this is how maybe a normal lung would appear, but somebody that is latently infected, yes, they have the bacilli, but as you can see, they have been contained. There's some defense, some way of protection, or to ensure that there's no replication of the bacteria. So these are the people that are latently infected. For our radiologists, yes, some of them say it's possible to pick latent TB infection from X-rays. There's a way they will be able to differentiate these lesions from these lesions. So where available, an X-ray can be used to rule out the presence of an active disease and to be sure that you are dealing with latent TB. So the active TB bacteria are replicating, they are circulating, you're able to get disseminated disease here. You're showing signs and symptoms because you're coughing, you could be having bloody sputum, and the rest because now you're dealing with a bacteria that is replicating. So the role of TPT is now to stop this progression, to ensure that those of us that are latently infected, the drugs can completely clear this so that now we have a healthy lung and now we don't move to this particular end. Okay. Risk factors vary. Again, this is common knowledge. The risk factor for TB transmission and infection are quite a number, but the first thing is infectiousness of the index case. If you had a TB patient here, that is bacterial, BACT confirmed, TB was detected through lab sample, compared to somebody that was diagnosed clinically, like the extrapulmonary TB. The ones that have the most infectious ones are the ones that have the disease picked, the BACT confirmed TB patients. So those ones, then it means if you interact with a person that has pulmonary BACT confirmed, your risk of getting it is will be higher, because here there's the presence of a cough, there's the laryngeal disease. If there's any poor cough etiquette, then they're transmitting the disease, cavitary disease, a positive lab result. So it means all this makes the person, the TB patient, to transmit more to the contacts of the people around them as compared to the other group, the extrapulmonaries. Environmental factors, and this is why we picked the healthcare workers. We work in an environment that is highly concentrated with the bacilli. We worked in small enclosed spaces. In fact, in Nairobi, what we are seeing is most of our hospitals are very congested. We're working in a very small compound, but make sure that we're offering all services. So our outpatients or service delivery points are very crowded. So there's poor ventilation, there's poor air circulation in the labs, and the matters to do with poor sample handling. All these then make our environmental, contribute to the environmental factors for TB. The other risk factor is classified under the exposure to the infectious case. For how long have you been exposed? How frequently? What was the physical proximity? And that's why we narrowed down. We said, yes, we've interacted with our workmates who are social contacts, but looking at the physical proximity, looking at the frequency of exposure, the duration, then that then varies. So compared to the household contact, you're likely to be more proximal. You're likely to be having spent a lot of time, including the weekends, with your household members and the likes. And then the last classification here is now susceptibility of the contact. Matters to do with immune status. So when you go to the next presentation and the next part of the presentation, and we'll be talking about clinical at-risk group. Clinical at-risk group as a group to be included to benefit from TPT. This includes the people living with HIV. It also includes the people that are preparing for dialysis, patients that are on chemotherapy. All this needs to benefit from TB preventive therapy. So at this juncture, we are able to differentiate between active and latent TB. But just to repeat, for the sake of all of us to understand, we said for latent TB, the bacilli lives in you, but does not grow. It does not replicate. So by that, then you're not showing any signs and symptoms. You cannot transmit it. And if it is not managed, then it can advance to active TB disease. For active TB, the TB is active, it is replicating, it is growing. So you're showing signs and symptoms. It can be transmitted because now you're coughing and the likes. So if it is not managed, then it can cause long-term complication and death if not treated. Allow me to skip this. These are things that we have talked about, so that now we go to the eligible populations for TPT. So you see somebody already typed in the chat that healthcare workers need to be included. Yes, we have our healthcare workers here to benefit from TPT. We have the prisoners and staff working in prison settings. Somebody made a joke somewhere and said, our healthcare workers and the prisoners are in the same WhatsApp group. By this, they meant that we are in an environment Our work environment or our daytime environment is almost the same. We work in a very crowded environment and the likes, with a lot of bacilli for tuberculosis and the likes. People living with HIV, this is a group that we've been handling. For household contacts, we've been handling the children below 5 years, but now we're expanding that to all household contacts. And then, as I mentioned, you have the clinical at-risk group, like the patients that are receiving immunosuppressants, patients that are preparing for dialysis, organ transplant, patients with silicosis. I don't know how many of us have managed the patients with silicosis. So all these are at risk of tuberculosis and need to benefit from TB preventive therapy. So we'll go through this population one by one, starting with the people living with HIV, and then proceed like that. Okay, so for people living with HIV, we know that HIV is the strongest risk factor associated with the development of active TB, with up to 40% of our patients, people living with HIV, progressing to TB disease after exposure. So the risk for people living with HIV is 21 times higher as compared to the risk among the HIV negative population. Annually, we see about 2% of our people living with HIV coming down with tuberculosis. The other thing about people living with HIV, and that's why we need to consider them, is the mortality. If you look at our TB patients, right now we're dealing with maybe a mortality of about 10% of our patients maybe succumb to the disease. But if you look at the group that succumb to the disease, you realize more than half of them are people that were co-infected. They had both TB and HIV. So early detection of the HIV status and treatment of latent TB reduces the overall risk of TB progression by about 33%. But now when combined with ART, because ART by itself is able to reduce the risk of TB among people living with HIV. But when combined now with TB preventive therapy, then the overall risk reduces by almost 100%. This is a study that was done in Côte d'Ivoire. It's called the Temporal Study. Maybe most of us have come across it, but it was showing the importance of giving ART and TPT at the same time. So the clients that were initiated on both were followed up for 2 years after completion of their TPT. And what we found out that generally the risk of morbidity among the clients that had started this ART and IP, but then it was isoniazid, there was a reduction in the risk of morbidity among them. However, the ones that had the combination of ART and TPT, they had the highest or the greatest protection effect. So by offering both, then you're not only preventing TB, but you're also reducing the risk of morbidity and mortality among this group of people. So what is the recommendation here that we are giving? The children that are more than 12 months and they're living with HIV, then they should be given TPT, regardless of the ART status, regardless of the previous history of TB, and even the pregnancy status. For children, the infants, the ones that are below 12 months, if they are living with HIV, that alone will not be an indication for them to receive TPT. But they will receive TPT where there's a known TB case. So they are a household contact. Remember why we are giving PHIVs, because we are assuming that they've been exposed to TB and they have a low immunity. So the children below 1 year, not unless there's a known case, most of them are indoors. Most of them are either with their family members in the house. So the risk out there, the risk of playmates, the risk of schoolmates is not applicable for this particular group. And that's why they will only be given TPT if there's a known backed confirmed TB case in the house, in the family, in the house. Okay, we will have instances where somebody will be diagnosed with TB first. And then as you manage TB, you do HIV testing, you realize that they're also living with HIV, meaning that they will not have received TPT. So we are saying TPT may be given immediately after a successful completion of TB treatment, so now to prevent future occurrences of tuberculosis for this group of people. I saw somebody had typed in the chat after how long. I think based on the regimen. I know people that are using the DTG, people living with HIV using DTG, and now they're on rifampicin because of TB treatment. Usually you take about 2 weeks now you super boost, yes, And then after 2 weeks after completion, then you will return back to the normal dosage of DTG. So for this, after the 2 weeks, then you can initiate TPT to ensure that future occurrences of TB or even relapse and reoccurrences of TB among this group do not happen. This question is usually asked, will we repeat TPT, even for us as healthcare workers? If I take TPT today, will I repeat? So what we saw in most of the documents that and the studies done, that TPT offers a lifelong protection. And there are some documented studies that clients were followed up 6 years later, 5 years later. I think I also came across one that's 12 years later, and the group of people that had received TPT did not develop TB by those years that I've mentioned. However, for people living with HIV, we're saying repeat TPT is not recommended among people living with HIV, not unless they become household contact. You know, PLHIVs have a weakened immunity, so it's good to also consider that. So you have a PLHIV, they received TPT years ago, they happen to now have another risk, an additional risk of being into a household contact of TB patient, then in that case, you can repeat. Now let's move to household contacts. Don't get tired. I hope you are all concentrating. Maybe just to confirm if my participants are on. Yes, my participants are on. And just to see in the chats if they're commenting anything. Yes, I see questions are coming. So this is an indication that, yes, I have my participants on. Okay, now we move to household contacts. As I mentioned earlier on, we used to offer TB preventive therapy to the under 5s, but it was seen that the prevalence of latent TB is higher among even the ones that are over 5. And why is it so? The over 5s are now, these are big children, they're outside there, they're school going. Most of them can, if it's in the estate or in the village, they'll be out there playing with their colleagues. So the risk, the exposure is higher as compared to the children below 5 years. So that is to say that then all of us, all the contacts more than 5 years are all at risk of tuberculosis, including the adults. However, why we started with the under 5s is because their risk of progression to active TB is higher because of the immune status. So if you have a child below 5 compared to a child over 5, the one that is likely to progress to active faster is the child below 5 years. So this is to say that household contacts, regardless of their age, have a significant or higher risk of progression to TB as compared to the general population. So they should be offered TPT after ruling out any signs and symptoms of active TB, regardless of the HIV status and also regardless of their age. Okay, so currently, as maybe this will come as a question, currently we are saying the contacts of DRTB patients are excluded from TPT, so they will not get TB preventive therapy, mainly because initially there was no specified regimen for this, but years later on, we saw that WHO recommended the use of the fluoroquinolones as TPT for this particular group. So the PMDT, the team that handles DRTB patients advised that we first of all reserve the use of levo among this group of people. So maybe years later on, we'll have them included. I know some countries are already using levo for the contacts of DRTB. But for us, now we'll continue with the normal screening that we've been doing for our DRTB contacts. If you get a DRTB patient, have the contact screened. If it's an offering the X-ray, have all that done, but you'll handle the ones that are symptomatic. The ones that are asymptomatic, then they will not get TPT. I'll skip this in the interest of time. So this is the recommendation that we are saying. All household contacts, that is regardless of their age, the children, adolescents, and the adults, of BACT confirmed. I'm repeating, of BACT confirmed, not all TB patients, yeah, should be given TPT after ruling out active TB disease. So the ruling out here is based on the national guidelines, and also if you have any signs and symptoms, then you should be offered the diagnostic options. Where available, we have LTBS tests to pick in infection, like the TST and the IGRA. That in Kiambu we use IGRA. TST may be available maybe in the private facilities, I don't know. But countrywide, we do not have TST. But these ones can be used to pick exposure to the TB bacilli. So it can be provided to the adults and the adolescents more than 5 years. Anyone below 5 years, you're likely to get false negative results. Anybody with low immune status like the PLHIVs, you can't also use this test because you're likely to get you're likely to get false negative results. But where these tests are not available, then we'll work with the symptom-based screening and proceed. This one is not relevant to this particular group. We move to the prisoners. Prison settings, again, the global risk of TB in prison is high, 23 times higher compared to the general population. There are so many risk factors that put our prison settings to be TB breeding area. Things to do with late diagnosis of TB. So you have an inmate, maybe the diagnosis of TB will be delayed. So that means they will have exposed or transmitted the disease to so many other inmates by the time that this diagnosis is made. We also have, sometimes you have inadequate treatment, maybe they do not complete, so the issues of loss to follow-ups are also high in the prison setting. Overcrowding, we all know that. Poor ventilation, repeated prison transfers, all these high HIV infection, malnutrition, substance abuse, all this then make our prison setting to be at risk of TB. Okay, but now we're saying even the prison staff, due to the constant interaction with the prisoners, they go into their wards. I was told they're called wards. They're not called the dormitories. During the day, they interact with them. They go into their cells and the likes. So then, that is to say, then the staff working in prison settings here, we will treat them as the healthcare workers. Yeah. So they also at an increased risk of TB infection. So now we'll include them in for TPT. So the recommendation for the prisoners here, we say screening should be done at entry to the prison setting and thereafter biannually to ensure that during the stay in the prison, then we're able to pick TB and manage them early enough. So when it comes to TPT, we'll not offer to all, but we'll offer to those that we are sure that they'll be confined in the prison for at least 3 months and above. This is to ensure that they complete their TPT regimens. The staff, again, we said they should be screened every 6 months, like the way we do for healthcare workers, and also get TPT once in a lifetime. Okay, now we go to the healthcare workers. This is us. So for us, we face a 2 to 3-fold increased risk of developing TB as compared to the general population. And the factors here are so many. But just to mention a few, we are constantly exposed to the patients that have been diagnosed, some and some that are not even diagnosed, but they will present in our OPD. They will be coughing. They present in the chemist. I have a cough, hepatitis, chest cough, and the likes. So that is to say, then we put them we are at risk of TB. Okay. So, and also the labs will be handling different specimens. As you handle the lab specimen for diagnosing TB, you're putting yourself at risk. I don't know how many labs have the protective devices and the likes. So the recommendation here is screening should be done at least twice a year. Yesterday we commemorated World TB Day. I don't know any of us that were able to receive screening services just to screen to know if you have influenza and symptoms. And also for the healthcare workers, remember, offering TPT does not mean that now you have conquered this fight, but we still need to work on our infection prevention and control measures in our health facilities. So how does our seating arrangement look like? How ventilated is our work environment and the likes? So don't say that because I've taken TB preventive therapy, then now I don't have to open the windows. All IPC measures need to be put in place. Okay, so again, we need to rule out any signs and symptoms of active TB disease before offering TPT. So the other clinical risk group mainly is because of their weakened immunity. I'll not go into those details, but these are patients that are mainly handled by the consultants. So we also have efforts to reach out to a number of consultants who are handling these at-risk populations so that they give TPT before doing the other procedures. We have some population here that in some countries, maybe they're receiving TPT. And even for us, we feel maybe they are at risk, like the diabetics, the risk for TB is higher. But for one reason or the other, we do not include them in the list of persons to benefit from TPT. So for the diabetics, I know the studies that gave this recommendation that we're talking about today was not done among diabetics, but currently there's an ongoing study in a number of countries that will be happening for up to 36 months, and it started, I think, last year. So 3 years later, we'll be able to see the findings, and maybe later on we'll see if the diabetics can be included as a risk population. Then these others, people who inject drugs, people who are on harmful alcohol use, the smokers, the homeless, because of their numbers and also issues to do with follow-up. So we asked ourselves, if we initiate TPT to the homeless, how easy will it be for us to follow them up? So for now, we said we'll not include them. Maybe we start with the populations that are well defined, see the uptake, then maybe later on we can have ways to reach out to these populations. Immigrants from high TB burden countries, we will see this in most of the WHO guidelines recommending TPT for immigrants. But this does not apply to a country that is already a high burden, like for us, Kenya. So you cannot say because I am coming from Tanzania, maybe it's a high burden, I'm going into Kenya, which is equally high burden, that you should offer them TPT. No, that will not apply. So this applies to the low burden countries for TB. So, and I think you've already seen this in your practice. There are some people that are traveling abroad, because they know that you're coming from Kenya, Kenya being a high burden country, that you'll be tested first before going into the country. So this is not applicable for us. So we're saying this can get TPT if they happen to be included in the other criteria for TPT. So you're a diabetic, but you also happen to be household contact, then yes, you can benefit from TPT and the likes. Okay, we have a screening algorithm. Mainly is to look at the signs and symptoms for the children and the adults, which I'm sure you already know. But in this, we developed an algorithm. This is just a snapshot of it. Below it, there's some also more content. But here we're looking at the adults. We need to rule out ascertain if there's any of these symptoms are present. And for the children specifically, the failure to thrive, reduced playfulness, the poor weight gain, very important for you to detect, to increase your index of suspicion for the children. So the ones that symptoms are absent, before going to initiation of TPT, you have to evaluate for the contraindication. And the contraindications have been listed below here. We don't want to offer TPT to somebody that has active hepatitis, chronic alcoholism, and the likes, active TB. So we need to rule out, evaluate for any contraindications. The ones that will not have any contraindications are the ones that we provide TPT. The ones that have a contraindication, whatever contraindication, you defer TPT, but now you manage, if something that can be manage that. Let them come back to you when they do not have any contraindications, then they can get TPT. The same for the ones that did not had signs and symptoms of TB. So these ones will be subjected to TB diagnostic options. And if active TB is diagnosed, then treat it and ensure that they complete the treatment successfully. The ones that were sent to the lab and you ruled out TB was not absent, you will manage whatever this condition was. Maybe it's pneumonia, maybe it's bronchitis. But now when they come back to us with no signs and symptoms, then yes, they can now come back to this arm. Okay, so that is it for the eligible population. Briefly, I'll talk about the test options and the treatment options, and we will end there. So for testing, there's no gold standard for diagnosing latent TB. However, the use of TST and IGRA can be used. These tests require a competent immune response. So now we cannot use them for the children below 5 years and people living with HIV. For it to detect a response, then they should be, the individual should be, should have good immunity. Okay, so the other thing, they cannot measure the progression. They cannot say like Rhoda has been tested and Rhoda is likely to progress compared to Boru, who has been tested. Boru cannot progress. So these are a limitation for this test. What they do is just to test her, is there any presence of the TB bacilli in this individual, and that's all. So for testing, we're saying use of the TST and IGRA or even chest X-ray is not mandatory, and should not be used as a barrier for initiation of TPT. So you cannot say because you've not tested with either TST or IGRA or the chest X-ray, then you cannot initiate TPT. For TPT, we did not want to create any barriers for access. So we're saying symptomatic screening then for TB remains the basic approach to diagnose latent TB. And even going forward, there are some counties that will get Nairobi. If you're coming from Nairobi and Kiambu, you're likely to get the IGRA. IGRA, yes, the interferon gamma release assay test. USAID has plans to procure that, but the rest of us will not have that, and we will rely on the symptom-based screening. So just to mention briefly of how these tests differ. So TST, I think some of us have interacted with this. It used to be available some years, and we used it a lot for even diagnosing TB in children. And even I know some private facilities that are still using this to to help the diagnosis of TB even among adults. So you inject 0.1 mils of the tuberculin PPD into the inner surface of the forearm. And then what we expect a skin reaction if you've been exposed. But remember, the people that we're testing here do not have signs and symptoms. If they have signs and symptoms and you test with any of this, then you are likely dealing with a TB patient. But if they don't have signs and symptoms and you test with any of this and they turn positive, then for sure you are dealing with a TB infection that is in the latent stage. So then you tell the client to come back after 48 or 72 hours to read the measurements for the duration that will have appeared. Anything more than 10 millimeters is considered to be positive, and you're likely dealing with an infection. IGRA more or less as the same as to how the TST works, but now this one it's a blood test. So you withdraw blood from the client. So the reaction here will happen in the lab, not in the body as compared to the TST. So it measures the amount of interferon gamma released by white blood cells of the person in response now to the MTB antigens. So again, if it turns positive, then you're likely to, and you didn't have symptoms, then you're likely to have TB in a dormant stage. For the treatment, we have a number of treatment options that were recommended in the WHO document, but for us, we picked these three. Isoniazid is what we had for a number of years, what you're calling the 6H. But now the new ones are 3HP and 3RH. So HP, this is rifampicin and isoniazid. This regimen is friendly because it's given once a week. So you take it to a high dose of rifampicin and isoniazid, I think about 900 milligrams of each. But the good thing is now we have a fixed dose combination. So that comes in 300. So you take 3 tablets and you're done once a week for 12 weeks to make it 3 months, right? So this one is recommended to somebody that is more than 15 years, the adolescents and the adults, regardless of the HIV status, both HIV negative, so the contacts can benefit from this. Healthcare workers can benefit. People living with HIV more than 15 years can benefit from this. The second one is 3RH. 3 meaning 3 months of RH, rifampicin and isoniazid. This one is given on a daily basis for 3 months, specifically for HIV negative population. Rifampicin interacts with a number of the ARVs, so we did not recommend these to children living with HIV. And then now anybody that cannot use any of this for whatever reason, including the pregnant women, now those ones you continue using 6 months of isoniazid. So let's look at each of these and see the benefits of each. So rifampicin and isoniazid, why we're including it? Right now it's available in child-friendly fixed dose combination. The same one that we're using for treatment of the sick children. It's soluble in water. It's flavored, I think strawberry flavored, so very palatable for our children. It's suitable for the children that are up to 25 kgs, but remember HIV negative. So any child who is more than 25 kgs then can use the RH adult, the RH adults based on the number of kgs that the child will weigh. But for the HIV, children living with HIV, we're saying do not give to patients on PIs or nevirapine based. I don't know what regimen most of our children are. If these are the regimens, then it's not conducive. And that's why we say the children living with HIV should use isoniazid. The new molecule, also the 3HP, we are anticipating better adherence. And for the facility that we visited in Nairobi, we have seen that completion's very good. 12 weeks, you're done with your dose and you move on with other things. Initially, we did not have the fixed dose combination. It was hard. The first count that we started with Kiambu, the uptake was a challenge because now a patient had to take 6 tablets of rifampicin and 3 tablets, I think, of isoniazid to make a total of 9 tablets. This was not very friendly. Okay, we do not have child-friendly formulations for now, and that's why we are saying the children that are more than 25 kgs now cannot use this because now swallowing might be an issue. But maybe in future, if we get child-friendly formulation, then they're good for us, and maybe most of our children can now move to this regimen. We have not had any evidence for use of this among the children below 2 years. So again, not recommended for children below 2 years. It is safe for people living with HIV on the RAL-based regimen, efavirenz, and also on DTG. So far, there's no interaction between 3HP and DTG. So since most of our adults are on the DTG-based regimen, then this drug is safe for them. However, any person on PIs, nevirapine-based regimen, are not recommended. Okay, or rather you need to super boost, but now we were advised by our colleagues from NASCOP not to recommend the super boosting. Isoniazid has been with us for a number of times, so it remains to be the regimen of choice for the children living with HIV on Earth, mainly the PIs and the nevirapine based. The cost is cheaper. This one is easily available. However, because it goes for 6 months, you're likely to have poor adherence, low completion rates for this particular regimen. Okay. So because of rifampicin is a new drug, we felt it's important to talk about drug-drug interactions for rifampicin and a number of things, a number of different drugs. So like the PIs and rifampicin, then rifampicin decreases the levels of PIs. So then we're advising them not to offer it to somebody that was on the PIs, let them use 6H. Again, for hormonal contraceptives, so a mother comes to you, she's on the hormonal contraceptives. Don't give rifampicin because she will come back pregnant and she'll blame it on you that I wasn't ready for a child, but hii dawa yako daktari, it has made me pregnant. So again, if possible, let them use non-hormonal methods or even barrier methods on top of the barrier methods for the period that they'll be using rifampicin. Remember, it's a short period. 12 weeks and they can go back to their contraceptives. AL, I don't know if there's any healthcare worker today from the malaria endemic regions. Rifampicin decreases the level of antimalarial significantly. So we are saying if the clientele will not have started TPT and they're diagnosed with antimalarial with malaria first, then defer TPT. If they happen to get malaria and they're supposed to get the TPT, their antimalarials in the course of TPT, what you do if they happen to be fall on the same day, so I'm supposed to take my TPT on Wednesday, and on the same day I'm supposed to take also my AL. So what you do, you defer TPT, you skip TPT for that particular week, then you can resume it after completion of the antimalarials. Okay, for this particular regimens, there's no interaction that is expected, so there's no dose adjustment that is required. I'll not go to these details. I think I will stop my presentation here, but it is important that you on every clinic visit, you assess if they are showing any signs and symptoms of tuberculosis. You need to emphasize on adherence. Remember, they're not patients. They are well human beings. So it's important to emphasize on adherence so that they complete. And also assessing for any ADRs. This will be very important. These are the different outcomes that we have. I will not go into the details of this. I think that a number of case studies will not go into the details of that. I think I'll stop there for my presentation. Thank you. Over to you, the other panelist or the host, Amina. I don't know who's coming next. Okay. Allow me to, if there's no one from the panelists that is going to speak, let me just pick the comments from the chat. I see if I can respond to them. Okay, where did the question start from? Yes, we are listening. Yes, we are with you. Nice presentation, thank you. Okay. Okay, I think this is where we started, Dr. Dismas Okech.
Sorry, sorry, I'm sorry. I'm having a bit of technical issues again. So thank you for the presentation. It was very elaborate. In fact, I believe you've answered a lot of the questions that were put on the forum. But one that struck the most was we can see a lot of people who are eligible. Do we have stocks that can keep up with the demand for everybody who's eligible for TPT?
Pardon? Come again?
One of the audience asked, do we have enough stock to keep up with the for the eligible criteria?
Okay, I don't know where that participant is joining from, but yeah, for these 11 counties that I'm going to mention, we have adequate stock. The 3HP, the 3RH countrywide, at the moment they could be having low stock status, but in the month of April they will receive, because we have received a lot of 3HP for TPT. So for the children below 14 years, in the month of April we'll have adequate. For the 3HP, the following 11 counties have: Nairobi, Kiambu, Kitui, Machakos, Makueni, Embu, Kirinyaga, Murang'a, Nyeri, Kajiado, Nyandarua. So largely the neighbors of Nairobi, the central and eastern, those ones have adequate 3HP. Isoniazid.
Sorry, if I may ask, what brought to the selection of those 11 counties to be the one? Is it because there's a higher burden in those counties?
No. Our commodities were coming in slow bits. Okay, the manufacturers of 3HP globally, I think we have 1 or 2 manufacturers. Okay. So everyone, the whole country that has rolled out these recommendations are all going to the same supplier. So our commodities have been coming in bits, like we received 20,000 doses or received 10,000, even 5,000 doses. So it was not possible for us to go full blown the whole country. We started with Kiambu and Nairobi because of the proximity to the city mainly. And now when more commodities started coming in, because of issues to do with transfers, you have patients that work in Kiambu or stay in Kiambu but work in Nairobi. And maybe they want to collect the drugs from where they're working. So we had to scale down in terms of the labor. So we went to Kajiado, like patients coming from Kitengela and the likes. Now we went again to Machakos, the people that live in Machakos work in Nairobi and the likes. So we've been doing that form of movement in terms of neighboring, so that in case you have a transfer out or those issues of collecting drugs from another working area, but I stay in another facility, in another county, we handle that. But now plans to increase, we also have plans to reach to more counties, like the coastal counties, beyond the eastern, the Machakos, Makueni, you go to coast, like Taveta and the likes. So those ones are being trained right now. And by April, they will also have 3HP. And then this other side, we have some more counties that partners have helped us to train, the Narok, Nandi, Kericho. So in the month of April, they'll also receive 3HP. So our scale up was mainly because of the commodities issues and also training of healthcare workers.
Yeah, another very good question is about formulation. Is it in syrup form for the young age group?
So for 3HP, these are in tablets, but the tablets are child friendly, so they can dissolve in water. Yeah, and these are the ones that we've been using for treating the sick children. Isoniazid specifically for the children living with HIV, we had suspension, but I don't know what happened. I think we no longer receive it. I think a lot of it expired on us. Maybe the consumption was low. So isoniazid right now, tablets. The same for 3HP tablets. Child-friendly 3HP not available.
Okay, sawa. So another question is, how do we collect specimen in children? Can you comment on that? Because probably some people are having challenges in doing that.
Specimen it means now you're dealing with a sick child, right? So the child has TB symptoms. Yeah. So these are not specimen for TPT or for LTBI or for infection. So
sorry. Yes, somebody who's infected.
Okay, so if the child has signs and symptoms, it means they are coughing, depending with the age, if they're able to produce sputum well and good. But for the very young children that are not able to produce a cough, to cough up and get sample, then you're largely relying on gastric aspirates, But now for the children, we have some new ways of detecting TB. That is TB using the use of stool. You realize most of the children will cough and swallow the sputum. So now the use of stool is one of the newest ways to diagnose TB in children. Yeah.
Wow. And how many places are equipped to actually do that test for stool and TB? So that which labs are able to carry out that specific test for stool in TB?
Oh, for stool, any lab that has a gene expert. I think the sensitization was done countrywide. Initially, there are a few counties that piloted, but with the findings, I think right now, I don't know if people can confirm, If but according to my knowledge, all counties right now are, as long as you have a gene, because you will do a gene expert, the same gene expert that runs sputum samples, the same one that will run stool samples for the children. Yes.
Okay, it's good to clarify that.
Yes.
A question for Dr. Ogut. I had interrupted him before the question for Crispin Nyambigo. He was asking regarding vaccine immunization. What's the point of immunization if it does? What's the correlation between non-immunized and exposure and fatality rates? And if there's any added benefit in getting vaccinated against TB?
So,
and in the interest of time, that would be the last question. So I don't, sorry, Rhoda. Okay, fine. You can go ahead, and maybe Dr. Ogutu can also answer.
Okay, so vaccination here, I assume we are talking about BCG. BCG plays a very key role, but now remember its effects wear off with time. Sorry, so it should be very useful for the children at an young age, an early age. But again, it prevents the severe forms of tuberculosis like TB, meningitis. I know right now we have very few patients who are suffering from that. So the role of BCG is mainly in the early age, young age, and to also prevent the severe forms of disease. But the protection wears off with time, and that's why you see now even adults getting TB over time.
Thank you. Any parting shot, because we were supposed to end at 12 and I don't want to keep the audience longer than this. But thank you. It's a wonderful presentation. I think you can appreciate most of the audience for actually saying they are very grateful and great presentation. Thank you for sensitizing us on what's happening global, nationwide in terms of TB treatment. We had an honor to screen our own staff in Kenyatta the last 2 days. I think the last count was almost up to 30, 40 people. I didn't get the latest update. But please, healthcare workers, let's not forget ourselves. Go and get screened. I remember
Sure.
I also got the latent positive. It worried me a lot.
Oh,
but,
okay.
But
Yeah.
thankfully, we are now empowered and we know how to go about it. So do you have any parting shots, Rhoda?
From my end, let me just say thank you for this opportunity. When you have new recommendation, usually you target to reach to all healthcare workers. So for sure, this platform has been very useful for me. I don't know where the healthcare workers are coming from, but wherever you are, kindly cascade this information to your colleagues. And if you're in a county that we're already implementing this, let's have your support in this, your uptake in this. Be our ambassador wherever you are. Thank you.
Thank you. Dr. Ogutu? I think
thank you. I'm there. Thank you very much. Thank you for the time. Thank you, participant too, for participating in this very important session. And just to add on what Rhoda had said on immunization and morbidity and mortality, she has clearly explained that it is preventing severe form of TB especially among the children, and otherwise it does not prevent you from getting infected with TB and progressing to active TB disease. So in terms of mortality, then if it prevents severe form of TB, which from where actually the mortality comes, it reduces indirectly the mortality in that way by preventing or patient from progressing into that severe form of TB, like TB meningitis. But otherwise, I'm happy that we were able to sensitize you on this, a very important part of TB. And the only thing I want to say is that TB is everywhere. We say TB anywhere is TB everywhere. And we are missing more than 40% of TB cases annually. And these TB cases are with us. Many of them come to the health facilities complaining of respiratory issues. But before they come to you, they visit other informal places, like maybe just buying drugs from a chemist, a small chemist in town, staying away again for like 2-3 months or weeks, coming back with the same symptoms, but now going to maybe, let's say, to a religious place, anaombewa. The third time now, maybe, which is after 3 or so months, they come to the facility, and it is a first visit, and so no one even suspect that this is TB. Not that no one, but maybe many of us will not suspect TB among them. So they are treated for upper respiratory tract infection, pneumonia, and other things. And then they go back, you know, TB is caused by bacteria. So these antibiotics that you are giving them will be effective to some level. So they will improve, and they think that they have been treated for pneumonia or upper respiratory tract infection. They stay for some time and then they come back. In Kenya, studies have shown that a patient comes to a health facility 4 to 7 times before they are suspected to have TB and investigated and diagnosed and put on treatment. And all this time, patients are transmitting TB in the community to the healthy population. One active TB case in the community can transmit TB to up to 15 people in the community. And if that, and we've seen that 10%, 5% of the TB infection progress to active TB disease in the first 2 years. And so if it progresses to active TB disease in the first year, among those ones who have been exposed, it will just increase, you know, the number of exposures in the community, and that's why we are not able to meet our target. So wherever you are, any person with any of those cardinal symptoms that we've mentioned should be suspected and investigated for TB. And that way we are going to reduce, you know, the 40% missed cases to less than maybe less than that. And by 2035, we'll be talking of actually achieving elimination of TB in Kenya. Thank you very much.
And thank you very much, Dr. for that very informative parting shot. I did not know that how severe the way we give antibiotics is, to the extent that we're missing out 7 times going to the hospital. That's a lot. Maybe to add, extrapulmonary TB, I think, is actually mostly undiagnosed than any even pulmonary, in my opinion. So thank you very much for the very great presentation to you and Rhoda. We hope to have you come another session again. As usual, this presentation will be uploaded in our YouTube channel. Or you can also get it from our website, and if you're a staff, you can get it from the KNH repository site. So thank you very much. The next session would be on elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. Just out of curiosity, Daktari, maybe you can just answer the one final question. Somebody asked if TB is transmissible in pregnancy, like if a mother can transmit it to a child.
Yeah, thank you for that question. And I think there's also another question on pleuro TB, extrapulmonary TB, especially pleuro effusion. So on that, on whether the patient, I mean, TB can be transmitted during pregnancy or something. Yes, it can. It does not get transmitted during pregnancy as such, but during, you know, the child in the uterus is fully protected by the sac. So, but once the wholeness of that sac will be interfered with, that is when now the fluid exchange will happen, especially during delivery, during labor, during delivery. That is when it can be transmitted. It's not very common, but it happens. It happens. And of course, after delivery, the child will be, the baby will be breastfed, and through breast milk, also there is a level of transmission that happens. Yeah,
and maybe the discussion can continue in the session in 30th March as well. So
okay,
again, I cannot overstate how grateful we are for the very wonderful presentation. Thank you very much. Asante sana. Until next time. Bye bye.
Thank you and bye.